I had plans to do traffic because I never know what I.
Right.
I feel like I never know what things.
Right.
But where it was mostly out, it was. I was here. I usually spend a half an hour on foot.
Oh, yeah.
So, are they thinking of keeping it?
Thinking about tomorrow?
Yeah.
A lot of people. So, yeah, just give it a half hour. It's really yummy. I'm good, how are you? A little lost. What? Oh, I know, it's a big complex.
Yeah.
I've been here once before, so that helps. Really? Oh, that's good. Well, I knew the general area. I just didn't the building. Yeah, exactly. I know. I tried to look up on my thing instead, and that's like 6 or 7, but I don't know.
Oh,
Started heading this way.
yeah, the numbers help. I was looking for the name, and I just kept going around looking for a sign, pointing me to the building, but
Right.
I didn't see anything. So I just stopped at the breast care center.
Oh, yeah.
I'm lost. Once they told me, yes, building 7.
Yeah, that was helpful.
And you go right there.
I think it's a tough name.
No. Crazy. I was so lost yesterday during that meeting. We didn't have a laptop, and then we usually have a conference room, and we use one of these for the conference room. So the conference room was being used. Our laptop was being serviced. And then Jeremy, our clinic manager, said, "Well, get on the call. Just use your phone." It's like, it's crazy in the background. I can't hear anything.
Right.
Everyone's like talking, and so it's a little lost. At the end of that, I told Jeremy, "Don't make me do that again." I couldn't hear anything. I couldn't focus because people were just like talking and laughing in the background.
Right.
It was chaotic, but we're just still trying to get things settled. They're still hiring people.
Yeah.
But we're getting to
Good morning, everyone. I think we should probably get started, even though we probably have a few more people coming in. So it's great to see you. How did it go getting here today? A little better? Yes, I'm nodding. Okay, good. This is a big campus, and I forgot that, and it can be hard to even find a parking spot. I'm glad you're all here. We will meet here as we're able, which is not going to be every meeting, but we'll let you know that in advance, and hopefully those times will increase because I think this is a better location in terms of being more central and off the freeway. So anyway, happy to have you here. So let's get started with some introductions again, just quick to remind us who we are. If you don't mind, we'll just go around, and obviously we have our names in front of us, but also perhaps could you tell us the clinic or organization you're with and maybe your role? We'll just quickly go through. So of course, I'm Mindy. I manage the medical home portal and I facilitate the UCCCN. So Christy. That's a lot of C's. Yeah.
Christy Hendricks. I work at Briner Pediatrics and I'm the health advocate. I'm Tiffany. I work at Briner Pediatrics and the nurse care manager. I work with Christy.
I'm Maria Castro. I work at South Main Clinic. It's a public health center for the University of Utah, and I'm one of the care coordinators there.
And my name is Adriana Alvarez. I work at South Main Clinic, care coordinator.
Athena Carolyn, University Pediatric Clinic, and I'm the care coordinator.
And Betsy Halgel, work for Wasatch Pediatrics in the Park City office, and I'm the care coordinator.
I'm Noemi Gay, and I work for Willow Creek Pediatrics under Wasatch as well, and I'm a medical home coordinator.
Carrie Nichols. I'm with We Care Pediatrics. I work in triage, CMA, care coordinator.
I'm Martha. I work at Jordan Valley Pediatrics, and I do.
I'm Kay Haynes. I send you the resources of the week and work with Mindy on the portal.
I'm Alexa Jarrett. I work at the Draper location for Waffle Pediatrics, and I'm care coordinator.
I'm Heidi Oliver. I work with the Department of Health and do quality improvement.
I'm Julie Olson, also in Medicaid. I am the Children's manager of the Children's Healthcare Improvement Collaboration Project.
I'm Renee Smith. I work at the Bear River Health Department. I do care coordination for a couple of the practices up there.
Renee, did you drive all the way here to?
No, my mother-in-law lives in Pleasant Grove, so I went down to the night last night.
Thank you for that effort.
I'm Bob Harrison. I'm a retired pediatrician and practice in West Georgia, and I'm just interested in what's happening in care coordination.
I'm Mimi Steele. I'm medical home coordinator at Southland Pediatrics. I'm Bonnie Alexander. I'm the front desk manager at Southland.
I'm Allison Steinhorst. I am the parent partner at Southland Pediatrics. I'm with Mimi and also
Gina Polomeni, and I work as the parent partner coordinator on our efforts in parent involvement in care coordination and medical home portal.
She has like 17 hats. Okay, so our topic today, as you may have noted from the emails, is really about family-centeredness, putting families at the center. So family-centeredness has been identified as one of the key elements in providing quality care coordination according to some of those higher level looks at what care coordination should be. And what our objectives are today are really to help try and have you take the role of the family and the parent and put yourselves in their shoes and try and see things from their eyes. To remember that we have a goal here to always ultimately help the patient, and in the pediatric realm, that's the patient and their family as an extension. And so trying to keep that at the core of what we do can, I think, probably be a little hard sometimes. And hopefully what we go through in this meeting today will help you to remember how to do that and have some tools around that. And to kind of help ground us and start us off, I think it makes sense to actually hear from a family, hear their story. And so we're very fortunate that we have Allison Steinhorst as a parent partner who joins us. And so we've asked her if she would talk today a little bit about her family story. So I'm going to turn it over to you.
So, just briefly, I was very honored when Gina called me about 4 years ago to be part of this project because this is so important. There are families out there who need this. They are under wit's end. I mean, there's so many different scenarios for families and their needs. So I'm very glad to be a part of this. So as far as my story, I have a 15-year-old son. His name is Parker, and I was going to bring a picture from this morning, and of course that talks about it. But he has cerebral palsy, and as a result of that, he has seizure disorder, and they labeled him as intractable seizures, which they're extremely difficult to control. And then 5 years later, we also were also very blessed to have another little boy who has ADHD. And there's very different. Sometimes I often say that Parker, with all of his medical needs and everything, he is my easy child because dealing with behavioral issues is so different than dealing with the constant just appointments and tube feedings. And I tell him to sit still, and he doesn't move. He doesn't talk back. So it's very, very different. But so the biggest thing is I want to just briefly talk about Parker mostly. My pregnancy was full term. We didn't have any idea that there was anything wrong. They noticed that when I would hold him, anybody was holding him, his eye would twitch And I mentioned that to the doctors, and they said to me, newborn babies are just twitchy. They don't have control over all their muscles yet. It made perfect sense to me. But it would twitch, and then later on he went to the well baby nursery. He was with me. He would twitch, and then he would start turning a dusky blue color. And so they took him to the NICU, and they hooked him up to the saturation monitors, and when he would twitch, he was losing his oxygen saturation. And so they ran a myriad of tests. They came in, they ran blood work to check for any type of bacterial infection. They ran anything you could think of, and everything was coming back normal. And in the meantime, he was pretty much staying in the NICU because he couldn't keep his body temperature up. The dusky blue thing, they didn't know when he was going to lose his saturation. And so after all of these tests, some pretty nasty nurses and pediatricians that were coming into my room accusing me of things that would have caused who knows what was wrong with him, they ran a CAT scan, and eventually they found that he had pretty significant brain damage. And of course you hear all the things. You hear the doctor came in and said he wasn't going to survive, that if he survived he would be a complete vegetable, he wasn't going to live, and if he lived, he would lay in a bed and drool. And that was going to be his life. And this was our first child. We had no idea. We were completely blindsided by this. And so we had to go through all of the emotions. I mean, I'm sure you guys have seen parents with new diagnoses, and you know what that looks like. And so it was finally determined that he had had in utero stroke, and that he had had up to 3 in utero strokes. And they could tell by the scans that it was very old damage, and they kind of timed it back to the first trimester. So the fact that he had survived that type of damage that early in my pregnancy, this child was my little miracle child. He was meant to be here, and he had a mission, and he had something to prove. And so because of this, he's 15 now, so in the last 15 years, we have dealt with, and I have a list, I'm going to read it or I'll forget something. We have dealt with seizures, specialists, many, many specialists, insurance companies, battles with insurance companies, hospital stays, close calls, surgeries, pharmacies, lots of medication, lots of side effects from the medication, scary times, lessons learned, knowledge gained, many, many blessings, and many, many amazing things. Miracles, wonderful times, many smiles, many giggles, many milestones that they told us he would never reach. I mean, if you're not going to live, how can you meet these amazing milestones? And so that's why we're here. That's why we're all here, because these children have something to say. They have a voice, and they can tell us. They have something to fight for, and we're here to help fight for these kids. So when Gina asked me to talk a little bit about kind of the lessons I learned along the way when I came on to medical home, it was a rough ride at first, Gina can tell you. My practice didn't know what to do with me, and I sat around for a really, really long time, and they didn't know whether to have me answer phone calls, and then we had a medical home coordinator who had legal background, and so everything was, well, she can't do that because this legal thing, and I see some smiles back there. And so that was difficult because I wasn't allowed to do certain things, and so then I wasn't allowed to do anything, and then, and then we didn't have a consistent medical home coordinator. We had a lot of turnover where we're at, and so it was a difficult ride, and I think some of the medical home assistants that we had, they tried to protect me too much. And so my piece of advice as a family partner is we will tell you what's too much. We will tell you if we can't do it. We can protect ourselves, so we know what's too much for us, and we know when our plates are getting too full. And so use your family partners. We are here because we have the experience and we know what it's like to have a kiddo with special needs. We deal with it every day. We have knowledge of even the simplest little things. I was on a phone call the other day with a mom who I shared with her a simple thing like it was a diaper issue. It was for a diaper that can make your diapers last longer. And she was like, what? Where are these and where can I find them? And then she had said to me, you work there? And I said, yes, our practice has hired me to come in one day a week now that the grant is over. And she, so it did get better. I will say that, it did get better. But she couldn't believe that I worked there, and she said, it is so nice to have somebody in the office who gets it, who knows what it's like and knows what it's like to try to find information. And just because I shared a simple thing with her, like something that can make her diapers last longer, which, you know, a lot of people, unless you're living that day to day, you just don't know about. So, yeah, anyway, so this is an amazing opportunity for us to impact the lives of these kids who don't have voices by themselves, and we can help the families and the parents to not necessarily do the work for them because they need to be able to learn how to do it on their own, but we can help hold their hands through it when they don't feel like they have anybody to turn to. So, I'm just going to
Wow, well, thank you very much, Allison. So I heard a bunch of stuff in there that I think I'll bring out throughout the presentation. But isn't it just fantastic that there are these folks who can access that bridge? So maybe one of the underlying things today, depending on your clinic or practice's ability and place and things, is to think about those parent partners and how they might be able to add that value, because they've lived it or they are living it, and they bring that unique perspective. How could they not be family-centered? So that's wonderful. Really appreciate you sharing that with us. So I think that segues all right into this next slide, which is really about families are their child's main care coordinator. They are the principal care coordinator. There's no way they can be. So I don't know if any of you are familiar with the Lucille Packard Foundation. It's based in California, and it really does focus on California kids, although the website has a lot of great stuff that anyone can benefit from. And so he's the Senior Vice President for Programs and Partnerships, Dr. Edward Shore, and he recently wrote a blog post on their website that was titled, Personal Advocacy, Why Families Will Always Be Their Child's Care Coordinator. And he's not someone to mince words if you read his stuff. He kind of gets right to the point, and he says that they are their primary care coordinator because families of children with special needs bear the brunt of absent or failed efforts to coordinate the care of their child. And it certainly is true, right? At the end of the day, they're the ones who have to make it work, regardless of what has happened in support of them or not. Families know best their child's care history and needs. Of course they do. They're their presence constantly. They're the best ones to understand what's happened and what needs to happen. And bottom line, the child in question is their child. So of course they're going to be that advocate and that primary care coordinator. So I'm going to read this quote. It's a little bit long, but I thought it was valuable. So again, this is Dr. Edward Shore. Individualized, proactive care coordination is a form of advocacy. This kind of advocacy, focused on a single child, is essential to maximize access to critical service and to optimize children's health and well-being. If it were available from outside of the family, it would also reduce the stress that family members experience, but it's not. However, families can and should be supported in their role as their child's principal care coordinator, as well as the principal care provider. So I read that and I went, oh my goodness. But in retrospect, it's true. In our country, in our current healthcare system, in our current economy, there isn't anyone else who can be that principal care coordinator for that child. And quite honestly, perhaps that's not what families would want anyway. They are that child's center, right? So they need to be in that role. But we can and should support them in their role. And so how can we do that? How can we support families in their role as the principal care coordinator? So that's something that we're we're going to try and answer, at least in part today. How can we put them always at the center? So medical home, right? That's the model that we're using for this practice-based care coordination. It's always thinking about doing things in the medical home model. So medical home really is primary care providers and families working together as partners. That's the take-home from this particular bullet. Partners, that's what we need to see ourselves as. And remember that we're working together. And the point of that is that we provide family-centered, comprehensive, and coordinated care. The first part of that bullet is family-centered. So that's got to be always forefront in what we're doing. So I thought this was great. Families of children with special needs have a wealth of experience as consumers of healthcare and related services. They're kind of the experts in this area, at least for their personal situation. They know what works, and they know what they need. They can describe what is and what is not helpful. And they are passionately committed to the cause. So we shouldn't forget this. And I think that, depending on where a family is in their journey, they may be a little higher or less in some of these areas, but ultimately, we should remember that they are, really those experts, and that we need to take advantage of that. So, Gina snapped this picture on a recent visit to Massachusetts, and I thought that I would pop it up there because she was pretty thrilled to see this, right? So Dusty was on that trip too. So they went back to actually learn more about coordination. Massachusetts does a lot of stuff in this area. And so this is actually at the Dartmouth-Hitchcock Medical Center. It was founded in 1999 as the first center for shared decision-making. So it's really the first place in the United States to encourage doctors and patients to make decisions together. And in the world of the child, that's the patient and their family. And so I thought that was pretty cool. We should definitely remember that. All right?
Yeah, I'm sorry, can I just jump in here?
Yeah.
When I've seen doctors, for me, the indication of a really good doctor is when I walk in and they say to me, Mom, what can I do for you? And they say to me, you tell me what's baseline here, what's going on, because you know him better than I do. I know that's a good doctor when they can say that to me, and we can have that conversation together.
So that them being able to take a step back and say, I don't know everything, but you know a lot. So let's share this. Yeah. And so when we do share that, I think everyone benefits, right? The practice benefits. They might do less or do things better the first time as a result of sharing information. Less time on their part, ability to take those resources and give it to other families who need it as a result. The family in question benefits, certainly, and ultimately the child benefits by everyone sharing information and partnering. And different perspectives around an issue mean more ideas and maybe more unique ways of tackling that particular concern. Services can have the continuity that they need when we're all talking and all sharing and on the same page. And that family can have that support that we were talking about as a result of sharing information. So Family Voices, there's a National Family Voices organization. Is everyone familiar with Family Voices? You guys know what that is? So Gina, do you mind just talking really quickly about Family Voices and Family Health Information Centers?
So Family Voices came about in about 1992, 93 as a result of the first initial healthcare reform efforts that were coming about in the Clinton administration. And as everything was being put together, they noticed that specifically children and youth with special healthcare needs were not being addressed as they were putting everything forward. And so a group of moms, advocates across the country that have been involved in many things, decided that they needed to set up a organization. They thought it would be there for about 5 years because they would help get the healthcare reform ready to go. It'd be perfect, and then we would just dissolve. Well, now here we are this many years later, and there is a Family Voices chapter. I have one here in Utah, in every state. And through those efforts, the Maternal and Child Health Bureau at the federal level seen the need to help not only from a family perspective, kind of the things that Allison was talking about in helping families from a peer-to-peer model navigate the healthcare system, but also be that voice for our children at systems level and help for systems change efforts, which we have been very effective at. And so MCH funds Family to Family Health Information Center in each and every state. Most of them are Family Voices chapters. Some are a combination of their Family Voices chapters, because there is also what's referred to, most people get confused, a Parent Training and Information Center in every state. Those are funded by the Federal Department of Education. So here at the Utah Parent Center, you hear that over and over in all of our slides and information. We decided that we would be under their umbrella so that we could really do a comprehensive piece of it. So they work on the educational pieces, we work on the healthcare pieces, and so in every state, both of those are also available.
And at the national level, the Family Voices organization has been working on an assessment that really is focused on whether or not families are receiving family-centered care. So this is available, and if you're interested in eventually, putting it into practice within your setting, we can make sure you can get a copy of that. There's 24 questions currently, and we're going to look at just a subset of them for purposes of time. But these are written for the family. So as you read these, maybe try and put yourself in the place of the family, and then it talks about the healthcare provider, and so that would be you and your team that's referring to. So let's just look at that for a minute. And again, we won't take too much time on these, but the first one is, my child's healthcare provider supports me in the role that I want to take in making decisions about my child's healthcare. So that's like that doctor that you were talking about, right? What do you need today? My child's healthcare provider and my family decide together on goals for my child's treatment. And there are a few examples up here. Less pain, improved health, better school attendance, more involvement in our community. And if you have any comments, please feel free to jump in. When we are making decisions about my child, my whole family. So, is that more involvement in the community going to impact the family in some other way that maybe is going to affect that balance, and maybe it will be difficult. So kind of take into account not only how the decision affects the child, but the whole family. My child's health provider recognizes my strengths in caring for my child. For example, I'm well organized, or I have lots of help from friends. I'm willing to try new things, or I'm willing to keep trying when something doesn't work right away. So that might change the course of treatment, right, or the course of a decision based on what the parents feel like they can provide and what they can do. My child's healthcare provider asks about issues that affect the well-being of my whole family. So this would be things that might be, non-medical in nature that you wouldn't think about initially in a clinic visit, but financial hardship, housing problems, trouble getting food, things like substance abuse, domestic violence. Those should come into play in taking a look at that whole family situation. My child's healthcare provider asks about my family's beliefs and practices when we are developing diagnostic and treatment plans. So that if there are cultural or religious things that need to be considered for a particular course of treatment, that those can be addressed right up front and with respect. My child's healthcare provider recognizes my child's strengths in making goals and deciding on care. For example, loves animals, or is married to the immediate family, sleeps well, those kinds of things might help change the course of a decision. So this next one talks a little bit about what a family could be, what families are. And Gina, is this person a Family Voices director in
She is the founder of, she's a national. She's the founder, okay. So I thought this was a great one. The culture of family. Families are big, small, extended, nuclear, multi-generational, with one parent, two parents, and grandparents. We live under one roof or many. A family can be as temporary as a few weeks, as permanent as forever. We become part of a family by birth, adoption, marriage, or from a desire for mutual support. A family is a culture unto itself, with different values and unique ways of realizing its dreams. Together, our families become the source of our rich cultural heritage and spiritual diversity. Our families create neighborhoods, communities, states, and nations. So, and I pulled some of this from slides that Gina has used many times, I think, to present about families, particularly those in special health studies. And so I thought these were great. These are what families want you to know. So from the voice of the family. Don't treat every parent or child you meet the same. We are different, with different needs, abilities, styles, personalities, and values. Listen to my ideas. I have spent many days and nights with my child and am closely attuned to any changes in his or her condition. I have observations worth listening to. Please reserve judgment about my family. You don't know what we've been through. Trust me and my family to care for my child. If I miss my appointment, trust that there is a good reason. Does this resonate with any of you guys? Have you? It has. I see some heads nodding. So, if you have any experiences that you'd like to share, please, you're welcome to chime in. But I'm sure that from a family perspective, these ring true as well. What families want depends on the difference between the support they already have and what they will need given their situation. And this is kind of that tricky part, right? Is helping them, so hopefully we know kind of their situation in general. We understand maybe the diagnosis and where they've been, but what they need in that moment or for that particular issue will be the difference between the support they've got, where they're at, and being that primary care coordinator for their child, and what they don't have, what they'll need for that situation. And so that's where we have to have that respect. Be listening to try and understand and be attuned to what they need at that point in time. So, with that in mind, we want to do a little role play today. Again, the objective of today is to get you in the role of the parent of the family and be seeing things through their perspective. So, we put together kind of a little way to set the scene up, but the bottom line is that we're going to have three versions of the scene where we've got a mom, her son, and a clinic and a care coordinator. And we're going to ask for your help in walking through some of these scenarios. I don't want you to do where we've got the script all written out on the screen for you, so there's nothing that you have to add with or anything like that. But we would like you to consider the tone that's happening in each one of these. So be thinking if you'd be willing to come up and play one of these roles as we move in to that part. But we're going to set the scene first. So. Actually. And we haven't really rehearsed this, so go with it, okay? And I hate role playing, so this is, we're both deciding maybe that's our next career. We're auditioning right now. Okay. Oh, I'm the child. So this is my child Joseph, and I'm the mom in this scene, and we are getting ready to get out the door to get to the doctor's appointment. So hopefully that kind of sets up and you know kind of where we're going. So, okay, ready? Okay. Goodbye, guys. I'll see you after school. I'm hoping that everything will go fine. I'm gotta take Joseph to the doctor's this morning, but I should be home in plenty of time after work to pick you up.
Joseph, did you take your shoes off again? We've got to go. We're late, as usual, we're late. Can we come? You can bring the iPad, you can practice your pieces that we were talking about, if you take it. But you have to put your shoes back on. Joseph, in a hurry. Can I get my shoes tied? The ones tied. The ones without the tie. I don't. It doesn't feel right. Okay. My sock is bumpy. Okay. Well, we better hurry. Do you still want to go to your school parade today? My sock is bumpy. Okay. Okay. I don't like it. That's okay. Remember what we talked about? Count to 3. I don't want to count to 3. My sock is bumpy. I don't like the way it feels. We have to go. You want to still do your parade today at school? Yeah. Then we have to go to the doctor's first, okay? Sit in the car. Buckle your seatbelt. Okay, we ready? Wait! What? I don't have my iPad. I need my iPad. Okay, I'll unbuckle. I don't have my iPad. Stay there. 5 minutes late again. Okay, here you go. Thank you. Everything good. We got everything for yes. Okay. We're here. We have every single light. Oh my gosh. Okay, so we're in the clinic, and I'll be the care coordinator, and you're a colleague of mine. So how are we this morning? I can tell you, we found out last night that my mom has a very sick. So I'm pretty much a mess, and I don't know how to do it too late. So yeah, I'm a little upset, and if you can just help me out. All right. So, let's see this right now. Yeah. Good morning. Hi. We have an appointment for Joseph this morning. We're running a little bit late. Yes, you have to adjust your appointment. You'll be seated. I'm real sorry. I'm hoping that you remember that Joseph has autism, and we try, but sorry we're late. Yeah, we'll work through it. All right. So with that, we're at this point, and now we would love to have someone come up and play the role of the mom. Joseph's mom. So honey, I'm stepping down from being mom.
I guess I've been on that other side.
So far, this was so much like a regular day when we tried to get it to the office. So anyone comfortable with the idea of playing mom?
I was a respiratory provider, so I guess I kind of know.
You're good. No, you're good. Okay, Nathan, you are Cynthia, okay? You're going to need to be able to see the screen, so let's put you here. You're Joseph's mom, and your script will be up there, okay? Oh, yeah. Okay. Hello. can you tell me what happened with Joseph since you were here last?
Well, he didn't get one of the slots into the specialized school that we applied to, and the waiver that is providing some of the services that we feel are helping him so much with his communication and behaviors is ending. I'm not sure what we're going to do.
I'm sorry to hear that. What would you like me to do?
I don't know what you're supposed to do. Find me another speech language therapist that is low cost or takes Medicaid. Help me figure out another option for school.
Well, I will do some checking and I'll get back to you. The doctor will be right in. Thank you. All right, so Cynthia's going to leave that visit. She's going to feel tired and down. Afterwards, a specialist will be referred to her. A suggestion for a new after-school program will be sent to her. But that's it for Cynthia and Joseph. And Anita is still very preoccupied with what's going on with her family medical situation. So, what do you think? What could have gone better in that situation?
You got to leave your personal life at home.
And how easy is that to do? Pretty darn tough, right?
And I also think from a parent's perspective, we have a lot going on, but sometimes we need to stop and realize that everybody's got a story and things are going on, and even though we don't know the behind the scenes, but realizing that there's days that people see us and just think we are the hardest to deal with people there because things are going on in the background. We have to turn around and remember that can be happening with anybody too. So it's that communication, even that nonverbal communication that's so important in the office.
Something I found that helped, because I've been on both sides of it. Because I'm well aware of our special needs issues, because they have a special place in my heart. If they're 10 minutes late to their appointment, I will give them a call and be like, is everything okay? Do you need to reschedule? When do you think you can be here? And I usually leave lots of time open so we can see people, because it's important to be seen. It's, really difficult. Like, my little sister's autistic, and, she's fully functional now because of the specialist, but, she'd have meltdowns like most autistic children. The little boy was a respiratory provider, had a lot of autistic meltdowns, and when we go to the dentist, and usually, as a caregiver, I call and say, like, I'm so sorry, we're running a little bit late. And they go, oh, yeah, that's fine. Because usually if the clinic is aware of the situation, and it's pretty easy because in my clinic it's just, Dr. Dad, Suzanne, and me, right? We all know who is who, and we all, deeply care for our patients. I think that's really important. So we'll just give them a call if we're just like, they're not here yet, that's not normal for them. They don't usually no-show. And so we try to make sure we give them a call and make sure that when they come in, we go, is everything okay? What do you need?
I'm curious, who else's clinic have a setup where that would be possible, where you could add a little time for a family, might have some other things going on that would make it difficult for them to get there on time? Yours does. That's fantastic. And what about the call if they're late, or I don't know, sometimes that would indicate they were probably driving and you don't want to make them pick up the phone, right? But the idea that there's that, reaching out. They don't try, right? Good. Good. But
from the parent's point of view too, I think if I'm having a moment and, oftentimes Parker went through a thing where I would transfer him into the car and vomit every time. And so then it's clothes, or we have a diaper issue, or there's always something, right?
It's a lot of special needs.
It's always something. Mm-hmm. And so your battery dies on whatever equipment you've got. And so I would always make sure I have all the doctor's information in my phone. I would always make sure that I would call. I would be proactive as a parent and call and say, I am coming I'm running just a little bit behind. Do I need to reschedule or can you still get me in? And more than not, especially as a specialist, they would say, no, we'll get you in here, we'll figure it out. I've never been turned down. If I've taken a proactive stance and said, I'm coming, we had an issue, I'm on my way. I've found that if I take initiative and I'm proactive as a parent, they're more appreciative of that than just showing up late. Well, right here. Right. Part of it, so I think a phone call,
a big part of why we call is one, to show that we do care because we think about our patients all the time. We go, oh, I wanted your house, so-and-so, we haven't seen them in a while. But when I make that call, it's to make sure that, one, they still want to coming, two, if everything's okay, because we really do care. Are you okay? Do you want to reschedule or are you on your way?
Fantastic. Yeah, definitely.
One of the things to recognize, I think, is when it's not appropriate to discuss the problem-solving things in the room. So there's been times when I've gone in to help a patient come up with resources, solutions to different, financing issues, and there's something big, like the biggest example I can think of is a 15-year-old autistic child went in. This mom's looking at transition issues. She's having big behaviors. Well, this child is just stressing the mom out in the room. They were done with the visit. This girl was done. And so I just looked at mom and I said, you know what? Right now is probably not the best time to discuss it. What's the best time to call you? Turned around and made that phone call when she had time to talk and I had all my ducks in a row for what I knew she was looking for right then, so I had some answers available. Probably not everything she needed, but I did have something to give her as well. So I think it's good to recognize, especially if you're having a stressed out day, maybe it's better to say, you know what, can I just give you a call and we can kind of reconnect when we have some time to problem solve.
That's great. Again, that's going to be being flexible and attuned to what's going on in the situation and not treating every family and every visit the same way. So I think that's a skill. And that's a skill that probably we can all get better at. Perhaps some of us come better equipped at the beginning with that, but I think we can all get better at that. But that is a big part, I think, of quality care coordination is understanding how to treat what's going on at the moment and understanding the constraints and things. So, all right, let's go to our next team. So, Melissa, thank you so much. All right, guys, take two. So now I need another front office person, and I need Gina. You're going to be the care coordinator. Allison, you're good. Okay. And in this one, I need another mom who's willing to do this with a slightly different setup.
I'll be your front office.
Oh, great. Okay.
Can I do that part?
Yeah.
Okay. I'll be the mom if you want to. I'll be the front office person.
Who'll be the mom?
I'll do it.
Okay, super. Sure, that'll be great. Okay. I'm just going to this person have your Actually, okay, so let's back up just kind of, let's have Mom and Joseph sit down, okay, and then sit down. Hi, how are you guys today?
Hi, good. I'm here to check in Joseph. Okay, great. Go ahead and have a seat. We'll be right with you. Thank you so much. Awesome. How's your evening?
Hello.
Hi.
Sorry to have you wait so long. Can you tell me what has been happening with Joseph since your visit?
Well, he did get one of the slots into the specialized school that we applied to, and the waiver
I don't know. Can you help me find an SLP that is low cost or takes Medicaid? I need to figure out another option for him.
I will do some checking and get back as soon as I possibly can. Maybe even before you leave today. Joseph, would you like to play with this toy? Maybe you could look and see if I heard that you like the numbers on that.
Yes, thank you. The doctor was right. Okay, thank you.
Cool. Okay, so in this case, before Cynthia and Joseph leave, so another referral is made to an SLP and a suggestion for an after-school program, but also a number for a local parent organization for maybe additional resources and some peer-to-peer support. Cynthia feels more hopeful as she drives home, and Nina feels better too. So the difference in how they treated Joseph too, and there you go, frustration level. Joseph not included. I want love. Any other observations?
So I didn't portray that, but everything that I'm going through at this point with my mother's illness and such, I kind of was able to put that aside because I was feeling like I was helping. And so I think even that situation made it so that the rest of the day I was able to helping down what we do.
I actually had almost this exact situation play out the other day. I was really, really busy in my office. One of the doctors came in and said, here's the situation, new patient, there's 4 kids in the room, 2 of them have autism, and mom doesn't know what to do and where to go, but do you want to just come in and meet us? And I'm like, yeah, sure, I'd love to. I come in, doctor introduces me, says, no, this is, walk away. I come in immediately, the kid comes at me with the toy. Can you draw this? Can you draw this? Can you draw? Like, keeps asking, and mom is wondering why I'm in there, and I've become the babysitter all of a sudden. And so the first thing I did is I have had a lot of time in the medical world, but I worked in schools for 4 years in kindergarten. The first thing I did was I just sat down with the kid. So I just took the doctor's chair with him. I started playing with his game with him while I'm talking to mom. Mom immediately relaxed because she's not worrying about trying to play with the kid and trying to get him to calm down while she's talking to him. So it was just, and then all of a sudden it was, relaxed. And the kid was back to his game, he was quiet, and mom, we were able to talk about it. So it was just, I don't know, trying to assess the situation very quickly. So
I think too, as a parent, when your child is going up to somebody at a doctor's office or honestly any type of office, and they start bugging the people that work there, you immediately start, it becomes a tense situation because you immediately want to say, don't bug them, they're busy, come here. But in a situation like that, when they encourage, like, you know what, no, it's okay, we could do this. You immediately, when she started talking about it, I could feel myself like, oh, okay, I'm okay. Because you feel like this is okay and they're here to help me. They love my kids enough that they're going to sit down and color with them while they talk to me. They're here to help me. And so, I actually started tensing when she told me that story. And I mean, it's one of those experiences as a parent when you start feeling more uptight.
So it sounds like maybe another skill that would be a great thing to try and develop would be to feel comfortable enough in your own skin that you could get down on the level of that kid, or those kids. How do you guys feel about that? Are you comfortable plopping down on the floor in your office and starting to color with this child? That might be something that takes a little doing, gets you out of your comfort zone, but that sounds like it could be the difference in that day for that family, and maybe that relationship between you and that family as well. So I think that's a skill. Another one. That's great. Oh, you guys, thank you. All right, so this is our last one. And in this one, we need a front office person, and we need a care coordinator, we need Anita, and we need mom. So we're having you step into both of the main roles. So who's up for it this time? you like this one. It's a good one.
I promise I won't be too hard on you.
Anyone?
I'd be willing to do it again if nobody else wants.
Okay, so Alexa's coming up, cool. And we know Miss will do it. Anybody else? All right, Miss, come on. Okay, so this time you'll be the care coordinator.
Oh no.
Okay.
How would I do that?
You're Anita. All right, so we'll have Gina will be the front desk. I'll here do this one. Okay, so the very first thing is so Mom and Joseph, you come and check in after that frantic drive where the iPad was forgotten and yeah, stress of unbuckling occurred.
It happens at my house all the time. Just throw that out there.
Oh, okay, it looks like you're about 15 minutes later. Is everything okay? I'm so sorry, hectic morning. We will definitely work you in. Please have a seat and I will let them know that you're here. Thank you so much.
It's not working. It's not working. Hi, Cynthia. Hi, Joseph. Hi. Sounds like the two of you have had quite the morning. My thoughts were not. They were bugging me. That's a bummer. Did you get it fixed? Yeah. My mom. Oh, good. We're very sorry about the wait, but we're happy you were able to get here. Yeah. Can you tell me what's happened with Joseph since your last visit?
Well, he didn't get into one of the spots in the specialized school that we applied to, and the waiver that's provided for the services. Still, I was helping so much with the communication and the year is ending. I'm not sure what we're going to do.
What you doing? Oh, wow. That's exciting. That's cool. Well, I'm sorry to hear that. How can I help?
I'm not really sure. We just found out, and it hasn't been all the way. Maybe you can help us figure out an SLP that's low cost for takes Medicaid. And I guess we need to figure out another option for school for him.
Okay. Having fun on his game. I was something Joseph might like. Boom! You want to try this? The game. You like that? Yeah. Cool. Let's pull up the medical home portal right now. Okay. Experience with kids on the spectrum. Joseph, would you be willing to try any speech language therapist? Boom. Boom. Is that a yes? Okay. I have some ideas for you, and we'll do some more checking before you leave today. Would an after-school program be something you and your family would consider for Joseph? That's great. School. You like school? You like school. Is it fun?
Thank you so much. And how have you been, by the way?
Oh, dealing with some health concerns in the family right now. Thanks for asking. I'm just trying to stay positive. The doctor will be right in. Bye, Joseph. It was good to see you. Bye. He'll be in just a minute.
Thank you. That was good. All right, so before Cynthia and Joseph leave, that special referral gets made and a suggestion for a new after-school program, and then the number to that local parent organization that might give them additional resources. And then Anita also asks about the family schedule. And she asked Joseph about his favorite iPad app. And she tells the mom that she'll note in the chart that for follow-up visits, they'll try and schedule these a little later in the day, so it'll be a little easier for mom and Joseph. Cynthia recognizes how busy the office is, and she thanks them for being so flexible and helping with challenges that come on days like this. She leaves feeling hopeful and energized for all the changes that she knows are coming in their family's journey, feeling as she's got people on her side. Anita feels better, too, about her personal concerns after having that positive interaction. So I think parties in here, including our front desk person, really recognize the reason for the visit. The point is to try and connect, share that information, figure out something that's going to work best for that family. And there was empathy on both sides there. And Joseph got included again. So anything else that you guys saw and recognized in that?
Well, I think it's important that we, do connect with the kid. The kid that comes in, if they see us as a friendly face, one, they'll be more cooperative, and two, the parents really appreciate it. I've had parents tell me, we love coming here because you guys are so nice and you care. I've gotten down and colored with the kids. They've shown me their games. We talk about games. I've drawn pictures, while talking. And even if, we have some time and the special needs child isn't selected at that day, there are some times when, I will, for lack of a better term, babysit, kind of distract the child so the other child's needs are met, because just because you're not special needs doesn't mean you're not important.
Very definitely. Well, I definitely hear it. It's probably not on any of your job descriptions, so that being able to connect with those kids is terribly important. It really is. They're the reason, right? Okay. We've kind of covered this. Gina, did you have a quick thing you were going to do?
I think, but I do think that one of the things that in that scenario is that sometimes that front office person, the check-in person, could be the most important person in that visit and how it will go. Because I think that we're so used to having, especially when you have children with behavioral problems, you get used to the judgments being made just from the community as a whole. And so you kind of carry that guilt and chip, and so if you get in and you have that first person that says, yes, we know that the offices, you have so much on your plate, your schedules are like this, but just recognizing that maybe there is a good reason, and even asking mom, how are you? Are you okay right this minute? Because you can see she's older. You might be the very first person that shows some concern and care. And sometimes you might even have mom break down right there, but it's, again, just recognizing that we get so many judgments on us just as a whole, that we're hoping that the physician's office, that medical home, can be the safe place.
And so in your offices, do you guys feel like your front desk staff have that empathy and that caring, or that's something that could be approached and worked on? Because I agree, that sets the tone for the whole visit right there when they walk in, right? So probably a really good thing to try and work on. All right, so family-centered care is the best practice. When families are involved in that shared decision-making, they're more satisfied, and they're going to be more likely to follow and maintain a care plan that they're involved in developing. So there are very real outcome-driven reasons for wanting to do this, even though it's also just the right thing to do, for sure. So. Well, now we're at the point in the meeting for our case of the month. Although I should pause and say, is there any other discussion that you guys would like to have around family-centered care? Any observations that maybe we've missed, or things you'd like to share from your personal experiences? Because I'm sure you have some.
Just speaking of the family piece, we have a family partner who works in our clinic as well, and oftentimes when families are looking for resources or they're really stressed out, I'll let them know also, if Liz is in the office, sometimes she'll go in and meet them. But sometimes I'll just let them know, you know what, we have a family partner, she has a child with special needs, would you mind if she gave you a call? And just help make that connection. Or sometimes I have other patients with similar diagnoses that have offered to do that as well. So this is kind of our main family partner, but then we have diagnosis-specific people. And so I'll say, would you mind if somebody gave you a call? you know, I've got a mom who's kind of been down in staff. And more often than not, people are over the top. Really, that would be great.
How many of you guys think that that's something that could happen in your clinics if you don't have a family partner there already? But tap into the families who have kids with special needs as a resource occasionally. Does that sound like something that you think about doing?
Betsy, how often your docs do that on? Is it yourself?
Usually they come to me and they're like, who do we have that will do this? But they're really good. It's taken a few years to make this kind of become the verbiage. But a lot of times it's like, well, we'll have our medical home team contact you. And that really just kind of encapsulates Liz and I. And the doctors have both mine and Liz's card in their room. So they can just let them out.
Do you have like forms that need to be filled out beforehand, you know, for like HIPAA and stuff?
So I get a verbal permission and document it. That's been okay, and we haven't had any problems that way. Our legal department hasn't commented on it.
I haven't said anything.
No, so I'm not upsetting the apple cart. How about that?
Right on.
No, and I think there's always that, especially within your office, because Liz is actually an employee.
Right.
So there's not such a, but the hurdle with HIPAA is, it's like, as long as the parent, even if you chart that it was a verbal okay, then that is what is needed. But most of the time, and I will just say from experience from all of our medical home projects over the years, with having parent partners in the practices, we have had business cards and such. And if you give them to a family without doing kind of that warm handoff or, you know, letting them know who this person is, that card is just going to go home and either going to be thrown away or put in a pile because a family doesn't know why they would be calling a parent or a family partner. So it's really, you know, within the process that you're making that connection that this is somebody that you're going to get all the resources from us in the medical home team. This is somebody that can help you navigate those resources because that's when the issues come down is when we're thinking, okay, we were told to do this, this, this. I don't even know which person it is to call because I called one number and they said, well, you need to call somebody else. So it's that referral merry-go-round. And so you have those families that can help navigate through that. And even if you don't have a parent partner, that's where the main line for the parent center or is able to get into us. And that's the role that we can.
We send a lot of parents to the parent center.
Yeah. So
it was
help them
like even back in the 90s with my little sister, my mom, you know, she works for DDI also. So it's just like, she's like, that's my favorite place. So it's good to have that resource.
So I heard two things. I heard be sure and get the verbal HIPAA okay when you're going to be talking with families about their potentially HIPAA information, PHI, and certainly for a parent partner, particularly if they're not an employee.
Our situation's a little bit different because I'm actually an employee of the health department, and then I do care coordination for multiple practices.
Right.
And so I'm not embedded in the practice. I don't actually see them when they come in for the appointments most of the time. And so the doctors will give them my information and ask if it's okay if I contact them. And then I will do the initial contact. And one of the first things I do is connect. I have flyers and stuff with our parent support group that meets up there. And the contact information for the woman that runs it. And then each month that they're having their meeting, we send out an invitation beforehand as to what's going to be covered, and then afterwards minutes as to what was covered so they can kind of see the value of it. And I've had, just within the last 2 weeks, I've had a couple of parents say, you know, it's not that they told me anything I didn't know, but it was so nice just to go in and talk to these parents and not have them roll their eyes when I'm trying to go through some of the experiences is what we're going because they've been there, done that, and they know what's going on. Ours is a little bit different, but there's still that parent support connection and support.
That's great. Great. And so when your docs make that call and try and get pass your information along and say, is it okay? Do they then put something in the chart? Yes. Okay. Yeah. So I think that sounds really important to me. Yeah. That came through, and then now I lost my train of thought with the second part. But I think it's just that connecting the, it says warm handoff if at all possible. And if it's not possible, then it's trying to frame it so they understand the value, right?
So we have a parent partner in our clinic as well, and we do the same thing. We get verbal consent for us to share their contact information. What they actually talk about in the call is totally up to them, and we kind of feel like once they've been connected, it actually doesn't violate anything because they're just parents talking to each other. However, we have found sometimes our parent partner learns things that she feels are valuable to share with us from a clinical perspective, and so she'll then reverse it and say, hey, do you mind if I share this back with the clinic? So that's been something we've learned as well.
So, yeah.
Does that get documented?
Yep. Anytime she emails me with things, I'll document it in an encounter that says, family gave parent partner permission to share this.
So she'll email you kind of that I got permission.
Mm-hmm.
And here's the information.
Yes.
And she can do that because she has to hold it with employee. If she didn't have secure email, how would you do that?
Good question. I don't know.
I think that's something that's just something to think about. Standard email would not have it.
Right.
Yeah. So if it's a parent-to-parent piece, so she's not under the same, if she's doing it as a concerned support at that point when she's contacting.
Right, but when that's going back to the record would be, so the parent partner communicating back to the care coordinator, to the physician, that would probably be protected. It's one of those gray areas that, if you can avoid, I would. If there's no way to avoid it, then I keep looking for a way to avoid it.
So maybe to address that a little bit, before Liz was an employee, we would have her join our meetings at least once a month, our mid-home meetings where we discuss different patients and cases and stuff like that, that she was involved in. And if she had concerns, she would address it just during that meeting. And that's something that she couldn't make every meeting, but when she did, she had notes that she would definitely pass along. And if she couldn't make the meeting, then she would give us a call with the information.
Yeah, phone call.
Yeah.
And ironically, that's
Who has a
well, the pharmacy keep that.
I'm a personal.
Right.
So how many of you feel comfortable with HIPAA? Because I'm not after hearing this.
There's always that little bit of it, you're just like, oh, not sure about that.
Mm-hmm.
I think everybody's got that little gap in it where it's just like, is that okay?
Mm-hmm.
I wonder if it would be helpful to try and write up some of the common scenarios, particularly that we just talked about. Parent to parent, different parent partner back to clinic, probably HIPAA, clinic, parent partner, probably HIPAA. That might be helpful. And then, everyone's own environment, you've got to figure out how you deal with that appropriately. The larger systems are going to have some of those things maybe more built in. But you still have to remember to use them, right?
I think the bottom line is the risk is exceedingly low, but probably not zero. And because HIPAA keeps getting reinterpreted, it's a moving target, and no lawyer would ever say, oh, yeah, go ahead and do this, that's fine. It's just one of those tough situations. My goal would be to try to minimize the risk, but do what's right.
Right. But I think that would also mean having a parent partner if they are, in fact, kind of in a formal capacity, having them go through some training. Right. Well, you guys, we were going to have Alexa do the case of the month, and she had to leave. So we only have 10 minutes left. I don't want to encroach on your time. We can either ask somebody to present us with a case, and we'll do our best for about 5 minutes, or we can bypass this month and just go to our wrap-up items. But I like cases of the month, so it's your call. If anyone has something on their mind, we can talk about it. And speaking of HIPAA, remember, when we're talking about it in here, to try and frame things in ways that wouldn't be patient identified.
Sorry to be everywhere. I'm actually currently dealing with a really interesting situation with one of my patients. His little boy, his parents are divorced. His mom has custody, and she's the sweetest lady. He's started having some behavioral issues. Dad has decided to, parents were on good terms. Mom did something to offend Dad's wife, and now Dad is trying to take control and manipulate the son, as I understand it. He's not allowing Mom to make appointments. He keeps coming in and telling us that she's an unfit mother. He's called the cops on her, and the cops go in, and every time they're like, this is a good home, there's nothing wrong here. He has lied to Mom about what has been said in our office. And, you know, we've been trying to find a pediatric behavioral specialist that can get him seen soon. And everywhere I've looked, they can't get him in until like late May or June, when this is a problem that needs to be addressed now. He's about 8.
What kind of behavior specialist?
He's just had a lot of aggression. He's very, you know, he's easily upset. He's a smart kid, you know, but he's just having all of these difficulties dealing with all of a sudden Mom and Dad aren't getting along.
So psychologist or psychologist? What kind of insurance?
One of the IHC insurances and Blue Cross.
Blue Cross Blue Shield. Have you tried empowerment counseling?
No.
They usually can get in within 1 or 2 weeks.
Let me write that down. Empowerment.
I don't know about Select Health, but they take Blue Cross Blue Shield. Do they take Select Health? I'm like 90% sure. Awesome.
So it's empowerment.
We have that in the portal, and I'll pull it up here in a minute. I hope that if not, we'll send it out.
They go to people too. Yeah, they can do.
They also deal with families.
Yes.
Okay, because I think that's important.
They do family and individual, and they go to houses and they do outpatients.
That's good to know.
And then Hopeful Beginnings goes to houses as well. They do family therapy, individual.
I have found that Hopeful Beginnings though has not been calling my patients.
Oh, they have
for months. They have not been calling my patients.
Oh.
So empowerment has been getting out there in 1 to 2 weeks. Yeah, I've referred 3 or 4 of my patients there, and they haven't called one of my patients.
Okay.
So
thank you.
Empowerment counseling.
Yeah.
Where is that? Roughly.
They have a Clearfield and a Midvale office.
Okay, Midvale.
Yeah.
Good to know.
I mean, is this something that you might think getting these stuff involved? It could cause more trouble for Mom, but there's Dad as well. I don't know.
I think they've already been involved, but it's Dad making all of these accusations that just flat out don't hold up. Mm-hmm. And Mom's just at a loss. She, you know, lots of hugs have been given because she's just so upset by all this. She's just like, you know, what am I doing wrong? Why is this happening to me?
Seems like potentially the Family Justice Center could help if they're having, I mean, if they're looking at, like, she wants to take full custody or things like that.
I'm thinking she's wanting to look into that because, you know, the child does not need the negativity, and he's been, like, talking back to his mom, calling Dad because his stepmom said, if you ever feel threatened or if your mom hits you, she'd be like, my mom's being mean, you know, because he's 8.
Right.
And so feeling threatened isn't clearly drawn out for him.
Yeah.
What would Family Justice Center do?
Good question. So from my understanding, they work really closely with the YWCA and can offer legal counsel for especially women who are trying to get out of situations that are difficult.
So maybe like discounted law services?
Yes.
Okay.
So here's Empowerment Counseling Services. They accept most insurance according to what we learned last time we connected with them, August 2014. And they do talk about parenting and marital issues in the services they provide, and then certainly, you know, coping, self-management, and these other things. So it sounds like that would maybe be a good start.
I've just been at a loss, you know. I go home and think about it at night, just like, because I really care about this family. They're very sweet.
Well, we'll pull up all of these. Empowerment Counseling, Hopeful Beginnings, CCFS, and Family Justice Center, and we'll put those on our resources of the month email that we'll send out in a day or two.
You guys are so helpful. That's what we're here for, right?
That's right. That's exactly right. All right. So to wrap up, all right. So we wanted to ask you. We'd like to start trying to bring in some local service providers or representatives of systems of care to do some short presentations in these meetings. I'm not sure that would necessarily happen every meeting, but as you're able and depending on what your interests are. So if you have some ideas right now, you're welcome to shout them out. Otherwise, in that email that we'll send out, we'll ask for you to contact us with ideas for those. So does anyone have anything that they kind of feel is a mystery to them in terms of accessing and would like to know more? Awesome. Okay. You guys know what awesome is?
Medicaid and Medicaid, Social Security.
We're going to jump right into the big ones, are we? Okay, that's a good start. So you think about it, and then as you can email us at any time, but we'll remind you to that resources of the month email. And then our next meeting will be on Tax Day, April 15th, so hopefully you'll all be done with those and you can concentrate on the meeting and not be thinking about that. And it'll be here again, although I don't think it'll be in these rooms. I think it'll be in the auditorium. So I'll put that information in the email next time so we can go straight to the right place.
So just questions on mental health, like maybe Valley Mental Health, like I heard good, not so good. So like I refer people there all the time, and about 80% of because of Medicaid, and I just if maybe anyone has experience with people that are good there, I don't know.
I've heard this, like, they're just like, I guess they're okay.
Was that recent?
Oh, just I mean the last year and a half that I've been referring, like, this is the place. It's just if someone has any experience, like, this is a good provider, send them there. I just have not.
I have a list of places where people can go that have Medicaid, so you don't have to refer them to Valley Mental Health.
Mm-hmm. Okay.
I'll
take that too.
I think so. I'll go back and double check, because those are all in the portal.
Are they? Okay.
So we're working on our search features, but in theory, you can go right into the search field in that list of services, that area, and you can even type in Medicaid, and then any record that has Medicaid in it will come up, and then you can look for it.
There's a list of different providers that you can go to that you don't necessarily, because I haven't had a lot of good response to Valley Mental Health. So there's a lot of places that you can go to that don't.
It's really hard to find a really good you know, mental health specialists. Like, I've been in and out of therapy my whole life, and I've had to jump from one to another, and it's really, like, it's not that they're bad, it's finding one that fits.
Mhm. That's really a challenge.
Yeah.
Particularly for these families, for sure.
And then, hey, do you have some lists of contact information for this group that they can grab if they didn't?
So they're over here on the table. If you didn't come, people pick them up.
No, we want to make sure that if you're comfortable having your contact information on the list to share, hopefully you got information to pay if you weren't, but your email and so forth is on our list so that you guys can contact one another directly if you like, for more of this kind of stuff, right? And don't forget that survey. We'll keep putting that link in those emails until, I don't know when. But it would be really super if you guys would help us out with that. It's not a lengthy survey, and it's not, you know, something that requires a lot of thought. It's super quick. But it would be really useful for us to have that information. And then, of course, we'll be sending out the resources as a month email in the next day or so. But yeah, April 15th here at the W Education Center. So
Is that at 8:30?
It'll be at 8:30. Yeah.
Thank you.
You're welcome. Thank you, everyone. Have a great rest of your week.
Oh, you guys? Yeah. Really? Well, I'll just clean up the site and then.
Una parte de uno porque voy a
Okay.